Welcome to the deep dive. Today we're looking into something called nerve sheath tumors, specifically in dogs.
Right. It's a condition maybe not everyone's heard of, but definitely important if you're a dog owner.
Yeah, we've got some pretty detailed source material here, and, well, the plan is to really break it down for you.
Exactly. We want to pull out the essential information, what these tumors are, how you might spot them, treatment options, that kind of thing.
Give you the core understanding without needing a veterinary degree.
That's the idea. Make it clear and accessible.
Okay, so let's start with something that really jumped out at me from the info. Something like 80%, 8 out of 10 of these tumors show up in a dog's front leg.
It's quite striking, isn't it?
Yeah, that seems really specific.
It is. And that high frequency in the thoracic limb, the front leg, is definitely a key takeaway right from the start.
So, backing up a bit, what are nerve sheath tumors? Just, the basics.
Okay, so basically these are tumors that grow from the cells that form the protective layer, or sheath, around nerves. We're talking about nerves outside the brain and the spinal cord, the peripheral nerves running through the body, and also the nerve roots that connect directly to the spinal cord.
Gotcha. Nerves outside the central command center.
Exactly. Now, you might hear veterinarians use a specific term, malignant peripheral nerve sheath tumor, or MPNST for short.
MPNST. Why the fancy name?
Well, it's actually because it can be surprisingly difficult, even under a microscope, to tell exactly which type of cell started the tumor. Was it a Schwann cell, a perineurial cell, maybe even a fibroblast mixed in?
So it's like a group category, because pinpointing the origin is tough.
Precisely. Older terms like schwannoma or neurofibroma were used, but MTNST is generally preferred now because it covers this group where the exact cell origin can be, well, a bit ambiguous.
Okay, that makes sense. MPNST it is. And back to that front leg thing, 80%. Is it anywhere specific within the front leg?
Interestingly, yeah. That 80% seems to be split pretty evenly. About half of them develop more out in the limb, around the nerve plexus, think sort of armpit, shoulder area, or the peripheral nerves themselves.
Okay.
And the other half are found closer to the spine, involving the nerve roots where they actually branch off the spinal cord.
So plexus peripheral nerves or nerve roots. 50-50 split, roughly.
Vastly, yes. And it's worth mentioning, this is primarily a dog issue. It's considered pretty rare in cats.
That's good news for the cat owners listening. Okay, so who gets these? Any specific breeds more at risk? Or maybe males versus females?
Well, based on the current information, there doesn't seem to be a strong link to any particular breed, and no obvious predisposition for males or females either.
Okay, so breed and sex aren't major factors. What about age?
Age definitely seems to play a role. The average age dogs are diagnosed is around 7.9 years old.
So typically middle-aged to older dogs.
Generally, yes. It's actually considered uncommon to see these tumors in dogs younger than 3 years old.
Right. So if you have an older dog showing certain signs, what are those signs? What's the first clue, usually?
The classic initial sign is often lameness in a front leg, but not just any lameness. It's typically chronic, meaning it's been going on for a while, and progressive, it gradually gets worse over time.
Okay, a slowly worsening limp in a front leg.
Yes. But here's a really important potential clue, something that can help distinguish it from, say, arthritis. Dogs with these tumors often develop significant muscle wasting, muscle atrophy in that affected leg.
More than you'd expect just from them not using the leg much, because it hurts.
Exactly. It's called neurogenic atrophy. Because the tumor is messing with the nerve supply to the muscle loss can be much more severe than what you typically see with a standard orthopedic issue causing similar lameness.
Ah, okay. The nerve signal disruption causes more dramatic muscle loss. Makes sense.
Precisely.
Are there other things owners or vets might notice on exam?
Yeah, potentially. You might see decreased muscle tone in the leg, kind of feels a bit floppy. And sometimes the flexor reflex, when the vet pinches the toe and the leg pulls back, that reflex might be weaker or even absent.
Okay. What about feeling for a lump?
Well, the vet will definitely try to palpate the armpit area, the axilla, but a distinct mass can only be felt in less than 30% of cases, so not always obvious.
So you can't always feel it.
No. Sometimes, though, the dog might show pain when that axillary area is gently pressed.
And depending on where exactly the tumor is located along that nerve, can other signs pop up? neurological things.
Absolutely. Location matters.
Oh,
For instance, if the tumor involves the nerve roots coming off the spine between the first and third thoracic vertebrae, sort of upper back, base of the neck area,
good.
you might see something called Horner's syndrome develop on that same side of the body.
Horner's syndrome. What does that look like?
It affects the eye and surrounding muscles. You might notice a droopy upper eyelid. The pupil on that side might be smaller than the other. The eyeball might look a bit sunken in. And maybe the third eyelid is more prominent. It's a collection of signs affecting one side of the face.
Okay, got it. What if the tumor is pressing on the actual spinal cord?
Then you can see signs related to spinal cord compression. Things like ataxia, which is like wobbliness or incoordination.
Unsteady walking.
Right. Weakness in the limbs, especially the back legs if it's lower down. And asymmetric proprioceptive deficits, basically. The dog loses some awareness of where its paws are in space, and it might stumble or drag its feet.
Wow, that sounds more serious.
It definitely can be. Another potential sign is a poor or absent cutaneous truncee reflex on the affected side. That's the skin twitch reflex along the back.
Oh, okay.
And if the tumor happens to be in the lower back, the lumbosacral area, sometimes a vet might actually be able to feel a mass during a rectal exam.
Really? Okay.
And one last thing. Though it's pretty rare, some dogs might excessively lick or even chew at the affected limb. Self-mutilation.
Oh, wow. That's distressing. So quite a range of signs depending on location and severity.
Indeed. From subtle lameness to quite significant neurological problems.
Now the big question, why? Do we know what causes these tumors to develop?
Well, it's an area where we don't have all the answers, unfortunately.
Yeah, often the case with cancers.
True. However, some research has found a mutation in a specific gene called the new oncogene in some dogs with these tumors.
New oncogene, so a genetic link.
It suggests there might be a genetic component or predisposition in at least some cases, yes, but it's not the whole story.
Is that new oncogene linked to other cancers too, or mostly this?
It is associated with some other types of cancer, but its specific role in PNSTs is still being actively researched. Scientists are looking into other potential genetic factors and maybe even environmental triggers too.
Right. So research is ongoing, but some genetic clues are emerging. Okay, let's talk diagnosis. Vet suspects this. What happens next? How do they confirm it?
It's really a process of elimination combined with specific tests. We call it working through the differential diagnoses.
Ruling out the other possibilities first.
Exactly, because other things can cause similar signs, especially that lameness.
Like what? What are the main things to rule out?
Well, number one is orthopedic conditions, arthritis, tendon or ligament injuries, maybe even a bone tumor.
Standard lameness causes.
Right. So a thorough orthopedic exam is crucial. X-rays are usually done. Sometimes more advanced imaging, like a bone scan, scintigraphy might be used.
And how do they tell the difference? You mentioned the muscle wasting.
Yes, that neurogenic atrophy being more severe than expected is a big clue pointing away from just an orthopedic issue. Also, how the dog responds or doesn't respond to rest and standard anti-inflammatory pain meds can be informative. Nerve pain often doesn't respond as well.
Okay. What else needs ruling out?
We also have to consider things that impress the nerve roots as they exit the spine, like a slip disc, intervertebral disc disease, or problems in the lower back, like lumbosacral disease, or even another type of tumor growing in the spine.
How are those different?
Often, those conditions also cause noticeable pain when the vet palpates the spine itself. That's not always a primary feature of PNSTs, though it can occur. And again, advanced imaging like CT or MRI is usually needed to really see what's going on around the spinal cord and nerve roots.
Got it. Anything else?
One more category is secondary nerve involvement from other cancers. Things like lymphoma or histiocytic sarcoma can sometimes spread to or involve nerves.
So cancer affecting the nerve, not starting from it.
Exactly. And the only way to really tell those apart definitively is usually with a biopsy of the abnormal tissue.
Okay, quite a few possibilities to sort through. What about lab tests? Blood work? Spinal fluid?
General blood work is usually run, but it's often normal or shows non-specific changes. Analyzing the cerebrospinal fluid, the CSF, that's sometimes done, especially if spinal cord involvement is suspected. But the findings with PNSTs are often not very specific either. might show slightly elevated protein, maybe a few cells, but not usually a clear diagnosis.
So not the most helpful tests for pinpointing this tumor.
Not always, but cytology looking at cells collected from the suspicious area can be helpful.
How do you get those cells?
Often using ultrasound to guide a fine needle right into the mass if one can be identified. It's called an ultrasound-guided fine needle aspirate or biopsy.
And what do the cells look like?
Under the microscope, the cells from an PNST often resemble those from other types of soft tissue sarcomas. So it can point towards a sarcoma, but maybe not definitively say PNST every single time without more tissue.
Okay. Now imaging. You mentioned X-rays, CT, MRI. Let's break those down a bit.
Sure, standard X-rays of the limb and spine are a starting point, but honestly, they often look normal or don't show the tumor itself very well.
Not sensitive enough for soft tissue.
Pretty much. Occasionally, an X-ray might show an enlarged opening where the nerve exits the vertebra, the intervertebral foramen, suggesting something is pushing its way through, but that's not common.
Okay, so X-rays are limited. What about ultrasound?
Ultrasound can be quite useful, especially if you can't feel a mass in the axilla. It's good at visualizing soft tissue structures. Sometimes giving the dog sedation helps get better positioning for the ultrasound and allows for those guided needle biopsies we talked about. The appearance of the tumor on ultrasound can vary, sometimes darker, sometimes brighter than surrounding tissue.
Better than X-rays for seeing a mass, potentially.
Yes. Then there's myelography. That involves injecting contrast dye around the spinal cord and taking X-rays. It can show if a tumor is pushing into or invading the spinal canal. It creates an outline you see. But because of where these tumors often are, myelography is only diagnostic in maybe about 50% of cases.
So hit or miss. Which brings us to
CT and MRI. These are really crucial, especially for tumors in the limb or near the spine.
which one is better?
MRI is generally considered the preferred method
Why MRI?
because it gives much better detail of soft tissues, the nerves, muscles, the tumor itself. MPNSTs typically show up as bright areas on certain MRI sequences called T2-weighted images, and they usually enhance, meaning they light up, after a contrast agent is injected intravenously. This helps really define the tumor's size, extent, and relationship to surrounding structures. It gives the surgeon the best possible roadmap.
Okay, MRI for the win on detailed soft tissue. Makes sense.
Definitely.
You also mentioned some other diagnostic procedures. EMG, nerve conduction. What are those about?
Right, electrodiagnostics. Electromyography, or EMG, is really helpful.
How does it work?
It essentially measures the electrical activity within muscles. Think of it like listening to the electrical chatter in the muscle fibers.
Okay.
It's excellent for differentiating that neurogenic atrophy, muscle wasting due to nerve damage, from disuse atrophy, where the muscle wastes away just because the limb isn't being used.
How does it tell the difference?
Damaged nerves cause specific abnormal electrical signals in the muscle, even when it's supposed to be resting, things called fibrillation potentials and positive sharp waves. If the EMG picks those up, it strongly points to a nerve problem as the cause of the muscle loss.
And is it reliable?
Very. In fact, EMG abnormalities are found in the vast majority of dogs with suspected or confirmed nerve sheath tumors. And if the tumor is near the spine, doing EMG on the epaxial muscles, the ones along the back, can even help indicate if the tumor has grown into the vertebral canal.
Wow, okay. That's pretty informative. What about nerve conduction velocity?
That test measures how fast and how strong an electrical impulse travels along a nerve. We stimulate the nerve at one point and record the signal further down. With a nerve sheath tumor compressing or damaging the nerve, the signal might travel slower, or the signal might be weaker, have a reduced amplitude.
I see. Measuring nerve function directly.
Exactly. And there are other related tests like F waves and H waves, which assess the nerve root portion closer to the spinal cord. They can help localize the problem and sometimes even distinguish between damage to sensory versus motor nerve fibers.
So a whole suite of electrical tests to check nerve and muscle function.
Yes, they provide valuable functional information that complements the anatomical detail from imaging like MRI.
Okay, that's a very thorough diagnostic process. So let's say the diagnosis is confirmed, PNST. What's the treatment plan look like?
The primary recommendation, the cornerstone of treatment, is usually surgery. And because these tumors are locally invasive, meaning they spread into surrounding tissues along the nerve, surgery needs to be aggressive.
Aggressive how?
Often this means amputation of the affected limb.
Wow, amputation. That's significant.
It is, but it often offers the best chance of removing the entire tumor, getting what we call clean margins and minimizing the risk of it growing back right there.
Is amputation always necessary?
It's very common for limb tumors. If the tumor involves the nerve roots near the spine, the surgery is different. More complex procedures like a hemilaminectomy or a dorsal laminectomy might be performed to remove part of the vertebra and access the tumor. But complete removal can be very challenging in that location.
Okay, so surgery is key, often major surgery. What about other options? Palliative care.
Yes. For dogs where surgery isn't an option, or maybe just to provide temporary comfort, oral corticosteroids like prednisone can sometimes help. They work by reducing inflammation and swelling around the tumor, which can relieve some pressure on the nerve and improve signs for a short time. But it's not a cure.
A temporary measure.
Right. Radiation therapy is another important option.
When is radiation used?
It can be used as the primary treatment for tumors that are considered non-resectable, meaning they can't be safely removed surgically. Or it can be used after surgery, especially if the surgeon wasn't confident they removed all the tumor cells, to try and kill any remaining microscopic disease and reduce the risk of recurrence.
Okay, radiation for non-surgical cases or after incomplete surgery.
Correct. And then there's chemotherapy.
Does chemo work well for these?
Traditional high-dose chemotherapy hasn't shown great success. However, a different approach called metronomic chemotherapy might be considered. This involved giving low doses of certain chemo drugs, like cyclophosphamide, often combined with an anti-inflammatory drug like piroxicam, on a more continuous basis. The goal is less about directly killing lots of tumor cells and more about interfering with the tumor's blood supply and environment. It's sometimes used for tumors that couldn't be completely removed surgically.
Metronomic chemo. A different strategy.
A different strategy, yes, with variable results.
So what about just managing the pain? These sound like they could be very painful.
Absolutely. Neuropathic pain coming from the damaged nerve itself is common. Effective pain management is crucial for quality of life. Medications like gabapentin or pregabalin are mainstays for treating this type of nerve pain. The vet will determine the right dose.
Gabapentin, pregabalin. Got it.
Yep.
Any medications to avoid?
Yes, an important point. Corticosteroids, like prednisone, should generally not be used at the same time as non-steroidal anti-inflammatory drugs or NSAIDs, like carprofen or meloxicam, due to the increased risk of serious gastrointestinal side effects, like ulcers.
Good to know. Don't combine steroids and NSAIDs.
Correct.
Okay, so surgery, maybe radiation, maybe metronomic chemo, definitely pain management. What's the long-term outlook? What should owners expect after treatment?
Well, one bit of relatively good news is that while these tumors are very aggressive locally, they don't tend to metastasize or spread to distant organs like the lungs, very commonly.
So less likely to spread far and wide compared to some other cancers.
Generally, yes, that's a positive. However, the big challenge is local recurrence.
Growing back in the same spot.
Exactly. Unfortunately, even after aggressive surgery like amputation, these tumors have a frustratingly high rate of coming back in the same area or along the remaining nerve stump.
How high are we talking?
The recurrence rate can be up to 72%, so nearly 3/4 of cases might see the tumor return locally.
Wow, 72%. That's incredibly high, even after amputation.
Even after amputation in some studies, it really highlights how infiltrative these tumors are along the nerve tissues.
That must be really tough for owners to hear after going through such a major surgery.
It absolutely is. It underscores the challenge of managing this disease long-term and the need for continued monitoring.
Right, so locally aggressive, high chance of coming back, but less likely to spread elsewhere.
That's a good summary of the behavior, yes.
Well, this has been incredibly informative, a really deep dive into canine nerve sheath tumors.
I hope it's been helpful.
Definitely. So just to recap the key points for everyone listening, these are tumors from nerve coverings. MPNST is the common term.
Right. Often tricky to know the exact cell origin.
And that striking statistic, 80% pop up in the front leg, split between the plexus peripheral nerves and the nerve roots.
A key identifier.
We talked about the main signs that progressive front leg lameness, but especially the severe muscle wasting, the neurogenic atrophy being a big clue.
And other potential signs like Horner syndrome or spinal cord issues, depending on location.
Diagnosis involves ruling out orthopedic and spinal issues, using imaging, especially MRI.
MRI being the gold standard for soft tissue detail.
And there's electrodiagnostic tests like EMG to check nerve and muscle function.
Providing that functional assessment.
Treatment-wise, aggressive surgery, often amputation for limb tumors is the mainstay.
With radiation and maybe metronomic chemo as other potential tools. And crucial pain management.
But the big takeaway on prognosis seems to be that high local recurrence rate, up to 72%, despite their lower tendency to metastasize.
That's certainly the major challenge we face with these tumors.
Yeah, that recurrence rate is really sticking with me.
It's a sobering statistic.
It really makes you wonder, doesn't it? Given that high chance of recurrence, even with aggressive surgery, what's next? What future research or maybe new combinations of treatments could start to offer dogs and their owners, more hope for preventing that local regrowth?
That's the crucial question researchers are grappling with. Improving local control is paramount.
Absolutely. Something for us all to think about. Well, this has been a very thorough look at a complex topic. We really hope this deep dive has helped shed some light on canine nerve sheath tumors for you.